you so much, ma'am, for generous introduction. And at the outset, I would like to thank Shreya, ma'am, for giving me the opportunity. I'll be speaking on the recovering the surfaces, ocular surface in lime burn. So as we know that acute lime burn is an emergency and we have to do quick actions, otherwise we may land up in the lot of sequelae. So my previous speaker already mentioned, so I'm not going into the detail. There are a lot of sequelae which can happen after acute chemical injury. So mostly we have three distinct etiological group we come across. Like the kids are most commonly affected by tuna packets in our area, and the young adults, they are most commonly affected of acute lime injury while using carbide gun to scare the animals to protect their crops. And the third, which is little less common and which is young ladies come because of some accidental exposure while whitewash. So the management is very crucial. Like first we have to do emergency management. Then we take a proper history to get an idea of the nature of chemical agent and the severity of it. And then we assess it properly and put a proper classification, like Dua's classification is very famous for this. And then we prognosticate the case and do counseling according, because these cases needs multiple surgeries and frequent visits to the clinic. So we have to counsel them well. And then we either manage medically or surgically depending upon the severity. So the purpose of management is get rid of all the lime which is exposed, and then we should promote the epithelialization. At the same time, we should reduce the inflammation to prevent further damage to the ocular surface, and the reduce long-term sequelae like symbol formation and fornicel shortening and the glaucoma, which may happen eventually. So coming to the emergency management, so the main theme is that we should irrigate the surface copiously with the either tap water or diaphoterine is a preferable product because it maintains better osmolarity and better maintains pH, though I have no financial interest in this. And we normalize the pH of the surface and wash out all the lime. It should be done as soon as possible. Someone can use this Morgan lens for the uncooperative patient. It can be fitted in the eye and we can connect it with the irrigation solution and it irrigates the ocular surface. So it is very effective for uncooperative patients. Coming to the medical management, the mainstay is lubrication. We have to lubricate well. Then steroids should be given to reduce the inflammation. Vitamin C to promote epithelialization, fastens the healing process. Doxycycline is again MMP inhibitor, reduce the inflammation, and anti-glaucoma medication if the glaucoma happens. So coming to the surgical management, the removal of the lime, and we should cover all the surfaces with the amniotic membrane, as ma'am already said, and allocelate is already covered. And one thing is tenoplasty we can do if there is chances of severe anterior segment ischemia and chances of phthisis of the eye. So the purpose of the lime removal with MT is to reduce the inflammation and promote epithelialization, reduce symbol formation, and while chronic, we manage the chronic lime injury cases, we get a better plane and better pannus dissection once if you put the amniotic membrane. So here I am showing a video that you can see the superior fornix is studded with lime, and we should remove all the lime. Here I am scraping it using a 15 number blade, retracting the lid and removal of all the limes from the superior fornixes as well as inferior fornixes. The corneal lime can be removed, which is very superficial, and then limited resection of the conjunctiva, because too much dissection will disturb the surface, and then I wash the whole surface to remove all the bits of lime, and then the raw surface is covered with the amniotic membrane. This will reduce the inflammation as well as protect the symboliform formation because it covers the raw surface. So I am using fibrin glue here to cover the whole surface. The extra part should be cut, and this is peripheral most part, which is stuck, and then I put a continuous suture also, because it's a kid, so better to put a suture to give extra protection to retain the amniotic membrane. And alloslate is already popularized, can be used for the acute lime burn. Mostly it is cadaveric. We prefer cadaveric from the young donor within 24 hours of the harvesting. It has advantages in the severe grade of the chemical injury over the amniotic membrane alone. It promotes the faster epithelialization and less symbiophron formation. And the most important thing is, though it is alloslate, but we need not to give immunosuppression, because we never bother about the rejection of these grafts. They're just to promote the epithelialization. One thing is tenoplasty, we can do the tenon's advancement also called. So this is, the purpose is to increase the vascularity to the limbus, and it provides vascular pedicle to the ischemic sclera. So basically it's a globe salvaging. Though there are a lot of symbiophron formation and the conjunctivalization of the epithelium of the surface, but it is just to salvage the globe. Otherwise, the eye may land up in the thysis. So here I am going to present a case. It's a, as you can see, there is 360-degree limbal ischemia. It's a young 13-year-old male after exposure to the lime, presented to us, and so we decided to do limbal advancement surgery here, and here is the video. Here I am dissecting the tenons from the overlying conjunctiva, and the necrotic sclera, ischemic sclera should be excised, and you can see that is small linear perforation is there. So I washed the exudates from it, dissecting the tenons from the conjunctiva, and then then sclera, and then again dissecting it from the overlying conjunctiva to make it free. And then I secured, since the perforation is just a linear perforation, so I secured with suture only, and I secured the whole tenons tissue to the limbus, as well as some bit I secured to the to cornea also with a tenno nylon suture, because my goal is just to vascularize the surface, nothing else. Though I know that it may end up in the severe symbiophron formation and conjunctivalization of the surface, but since the purpose is to promote vascularization, and then I used an amniotic membrane over it to give a protection and anti-inflammatory effect of the surface with the help of amniotic membrane. The extra amniotic membrane was excised, and it is again use fibrin glue to stick it well, and then secured with the sutures also. So this was the result. You can see the first post-op day picture. It is a swollen amniotic membrane. Then the 1 month follow-up, there was a central epithelial defect, but the surface was vascularized very well. And in the third picture is the 6 month follow-up, and there is a formation of some granuloma, but the surface is vascularized very well, though there are a lot of symbiophron and ankyloblephron formation, but I am happy because which ultimately solves the globe. Now sometimes in acute lime burn, we have a lot of intrastomal lime cases also, and these are the very difficult to pick them up. So, and we know that the lime has a peculiar property that it is due to membrane saponification, it goes deeper and deeper into the layers of the cornea. So what we do, we should not bother about the intrastomal lime. We should let it consolidated in the posterior layers of the cornea. And I just want to share one such case where the lime was settled to the posterior corneal lamella. It's a 21-year-old male post-carbide gun injury. The vision was PL, positive with PR, inaccurate, and we can go for penetrating keratoplasty also, but as we know that chemical injury is a high risk for penetrating keratoplasty, and you can see in the AIOC that whole the lime is settled in the posterior lamella only. So we apply here an unique approach that is DLEC. DLEC is the deep anterior lamellar endothelial keratoplasty, deep lamellar endothelial keratoplasty, where I resected out, first I split the cornea into two halves using this crescent knife as well as this blunt dissector. Since as you can see, the clarity of the instrument is here, means the anterior lamella is free of lime. And then I bisected this posterior lamella and resected out this posterior lamella using curved Vannas scissor from these two halves of the and you can see the posterior lamella containing almost white, containing all the lime particle, while the anterior lamella is relatively clear. And then I dissected the donor for the posterior endothelial keratoplasty. We use this anterior lamella for larger therapeutic graft also, so we always preserve this anterior lamella also, and resected out, shaped the posterior lamella and then inserted using this cystitome in place of the posterior lamellar defect, and then put air, and then I reposit the lamella and secure the wound with the continuous suture. And this is the early postoperative picture. You can see there was some clarity with on AIOCT. There is very well opposed posterior lamellar endothelial graft, and this is 9 months postoperative, and the vision was retained to 660 with clear visual axis, and there may be some residual lime in the periphery, but we should not bother about that because we made the visual axis very clear, and you can see the graft is also well opposed here. So my take-home message is it's a acute lime burn is an emergency surgery, emergency management, and we should assess it properly and then prognosticate. We get rid all the limes and amniotic membrane to protect the raw surface with or without yellow slate to promote epithelialization and reduce inflammation and symblepharon formation. Tenoplasty is also to handle the anterior segment ischemia, is very useful, and intrastomal lime should be dealt later. And one message I want to convey, that prevention is always better than cure. So we should ban all these lime pouches and the use of these carbide guns. So thank you so much for your patient listening.
Thank you, Dr. Gautam, for presenting wonderful cases, different varieties of